Janki, you do the introduction, okay?
Yes, sir.
We are going live in 5, 4, 3, 2, 1. We are live now.
Welcome everyone on the platform of Orthopedic Research and Education Foundation India. Today we have Professor Ananda Kisor Pal sir, who is teaching us about common mistakes what examiner can do while examining a case of a limping child usually. And actually sir needs no introduction. So over to you, sir. Thanks, sir.
Good evening, Dr. John Mukhopadhaya. There is an excellent effort for the PG students, and this sort of program, I think, that will be for immense help for basic knowledge and learning. So, without any wastage of time, I just want to start my program. That is the limping child. Actually, common mistakes. Actually, we have started the series. There is a common case and common mistakes, and especially we'll go for the finer details of the limping, especially in the children, because the gait examination is extremely important for all ages, but for the child it is very difficult because there are some problems because sometimes they don't cooperate. I'll already incorporate some videos where they are very difficult to understand what is the exact gait. And this limping, I'm giving the assurance to all the students. If we know the art of examination of the limping, and that is basically that makes your sense to understand what is the disease we are going to examine, and that would immense help for coming to the diagnosis and ultimately for management also. So just some basic slides. Like the approach of the patient slide, there is some you have to take the history. There's a specific purpose to categorize the disease. It has a protocol, as you know. There's some body, there's history of present illness, chief complaints, present illness, history of present illness, past history, personal history, family history, and menstrual history. And these are the consisting of the structures also. Now, how to start that history? This is the basics. That's 7 S questions, like the 6. All question starts with the S. So that is why my opinion is called 7 S questions. There is 6 starting, side. Next, symptoms. It may be local or symptomatic, span and duration, spread. There's a progress and the severity of the systemic or cardinal symptoms. So if the systemic and cardinal symptoms are present, that indicates the severity of disease. And the progress, some diseases are progressive, some are not progressive. Duration, that means some are very short duration, some long duration. And depending on these 7 S questions, we can categorize the disease from the history, like traumatic, infective, inflammatory, neoplastic, degenerative, neurogenic, like this. Now, just elaboration of the chief complaints. Basically, we have to understand the different pain. Maybe basically the 3 categories of the pain in orthopedic cases, like the mechanical, inflammatory, infective, and neoplastic. And I've just special mentioned what is the rest pain. Rest pain basically is the pain experienced after taking some rest in supine position, which causes some vascular congestion. That may be the cause. There's several other causes, which is most commonly due to vascular congestion, and that is known as the rest pain. And there are symptoms of progression. So sometimes they already told there are some diseases are progressive, like tuberculosis or the malignant disease. They are progressive disease. So how to know the disease is progressive? Basically, the symptoms are there is deteriorating. Like pain is increasing, everything, or the activity of daily living are gradually become restricted, or walking distance is gradually restricted. So these 3 points, if these 3 points are present, there is deterioration of symptoms, the gradual restriction of the activities of daily living, and the gradual reduction of the walking distance. If these are present, that indicates the symptoms are progressive. So disease is progressive. Like example is it is a tubercular. Depending on suppose there's a pyogenic and tubercular. Pyogenic is not a progressive disease. Once the initial brunt is heavy, but it causes a sudden halt, like the attack in the Taj attack in Mumbai. So that is like a pyogenic attack. But that is initially the system becomes aware, and that causes halting of the disease. So this is not a progressive. But tuberculosis is like a thief. It is not a dacoit, it is a thief. So they can steal the important wealth from the body. Like suppose it is a noble is stolen. It is stolen forever. It is lost forever. So that is how there is known as a progressive disease. So tuberculosis is a progressive disease. So the symptoms are deteriorating, gradual restriction, daily living, and the walking distance. So these are the signs of progression. Now, how to categorize the disease depending on the pain? Pain, I already told, there are different in orthopedic disease. Basically, there are 3 types of pain: mechanical, inflammatory, and infective neoplastic. And I'm just going to describe only single questions, like what is the aggravating factor and the relieving factor. So even in a very, very busy OPD, you can easily categorize which case is a mechanical pain, which disease causes inflammatory or the neoplastic. So if the aggravating factor is the activity and the relieving factor is the rest, it is a mechanical. Just opposite, the aggravating factor is the rest and the relieving factor is the activity, it is the inflammatory. Whereas in infective neoplastic, as the cause is always present, so there is no relief at all. So activity can aggravate the factor, aggravate the disease, aggravate the pain, whereas there is no relieving factor. So that is the infective neoplastic nature. Now, general survey, I'm not going to detail. There is alert, conscious coverage, everything we have to take. Now, examination protocol. So this is basically, there are 7 broad categories, and each category is divided into 3 subcategories. I'm not going to detail, of which the most important is the gait. For the lower limb, is first step to examine the gait. That is why gait, will discuss about every points, every very, very minute points of the gait. And in our other cases, like common mistakes, common case series, we'll discuss about the other details. Now, the gait, I already know the hip, that it involves, there are several hip motions. Hip motions, basically, is a 15 to 25 degree flexion is required for the hip motions. A knee is a 0 to 60 degree knee flexion, whereas the ankle is 0 to 30 degree, 0 to 20 degree, 10 to 20 degree knee ankle flexion is required. Dorsiflexion, that is 10 degree dorsiflexion, 20 degree plantar flexion is required for this gait. And the gait can be divided into stance phase and swing phase. Basic involvement, basic point is the stance phase is on an average 60% of the total gait cycle, whereas the swing phase is the 40% in a normal gait cycle. Now, there are several sub portions, like stance phase is subdivided into heel strike, foot flat, mid stance, heel off, and toe off, whereas the swing phase is divided into 3-1, is early swing, mid swing, and the deceleration phase. So this is the category. Now, gait examination. How to examine the gait? There are prerequisites. Now, prerequisites are it is A, B, C, P, A, C. Like the A is basically, it is the adequacy. Which adequate features are required? It should be patient should be adequately undressed. I'll show you how it is known. Next is we have to walk barefooted, straight, at least 20 steps. That is 3 meter walking is required at usual pace, usual normal speed. Now, any abnormality from bipedal unassisted gait is known as the limping. If we categorize, normally our orthopedic gait can be divided into stable gait and the unstable gait. In unstable, there are several names like the lurching, Tenelbach gait, there are similar unstable gait. Now, stable gait, there are basically 2 types. It may be antalgic gait or painful gait, and the short limb gait. And once there is a limb length discrepancy is more than 2 centimeters, that leads to short limb gait. So this is very, very important slide. Please concentrate on this slide. So gait examination, there are several methods of gait examination for the orthopedic clinical examination purpose. There are basically the observational gait analysis is most important. And we have to observe the patient walking, as I've already told, what is the art of walking. And we have to observe from the front, from the side, and from the back. Basically, what are the points to be examined? There are physical points and the functional points. Now, physical points we have to examine whether the patient is walking bipedal unassisted. If it is possible, then only the other features will come. If it is in the assisted gait, then there is some special feature like crutch gait, or there are different other gait. So for examination and for clinical purpose, first we have to see whether the patient is able to do the bipedal unassisted gait. Then the body parts to be examined, first from the face to toes. And we have to see the face for the painful facial expression. Next, we have to see the shoulder, whether it is going up and down or swaying side to side. Next, the trunk, again, similar to that will follow the shoulder, and the lower limb joints, hip, knee, ankle, and foot. If there is any abnormality, the structural abnormality or the deformity, then we have to note it. Now, the functional basically is the components. You have to see the components, stance and swing phase. I already told stance phase should be more than the swing phase. If the stance phase is less than the swing phase, it is very abnormal. So you need not remember what is 60, 40, everything, but need not remember. You have to remember the stance phase should be more than the swing phase. This is most important. Next is the cadence. Cadence means the pace, or basically it is the speed of the gait, that is slow or rapid. Next is the stability. Stability is the means tendency, whether the patient is walking with tendency to fall or not. That is known as the stability. Next is the foot progression angle. So what is foot progression angle? The one the patient walks in this manner. So normally there is the outgoing. There is normal outgoing 5 degree in children and 30 degree in adults. This is known as the normal foot progression angle. So this is if it will be less than 5 degree in children, less than 30 degree in adults, it is an intoeing gait. It is more than that, it is an outtoeing gait. So basically it's the mnemonics A, B, C, P, A, C. A is for the adequacy of undressing, adequacy of amount of walking, adequacy of barefooted walking, and normal speed. B for the barefooted walking and the body parts, bipedal unassisted, barefooted walking, and when we check the body parts. C for the components, you have to see whether the stance phase is more than the swing phase. With P for the pace, we have to check for the foot progression angle and the painful facial expression. S for the stability, you have to check whether the patient has a tendency to fall, and C for the, again, is the cadence or the pace. So A, B, C, P, A, C is the mnemonics. During the gates examination, you have to check in every gate. So suppose this is the gate you can see here. So basically, you see what is happening. There is swinging of the shoulder in coronal plane. Similar thing is happening, as you can see here. See the swinging of the shoulder in the coronal plane. But they check this one. Check this. So this is the movement is going up and down. As you can see here, see this, check this movement. Yes, check this movement. Movement is going up and down, and see the foot. There is definitely a short limb gait. So there is a single component. In that case, if we check the shoulder trunk motions and also the foot, that is sufficient enough. But see this component abnormality, as you can see here. It is not working. It is not working. So basically, there's a component you have to check the short stance phase and painful facial expressions. If the stance phase is short with painful facial expression, it is an antalgic gait. Its etiology is inflammatory, infective, or the pathological fracture. So it is a most important antalgic gait. If there is antalgic gait, we have to check first the anterior hip point tenderness, and next is the hip motions. Now, depending on that, we can check if all motions are symmetrically restricted. It's a global restriction. So that in that case, if the fair range of present but terminally painful, it is synovitis. Whether the minimal amount of range is present but whole range is painful, it is known as the arthritis. Whereas some movements are grossly restricted, some are relatively unaffected. That means a sectorial restriction. That means a mechanical problem. So this from antalgic gait, we have to check these points to come into the different diagnosis. Now check this one, this gait. As you can see here, see, the shoulder is swaying side to side as also up and down. So this is the combination because of the significant shortening. So there is a combination is occurring. So this is the combined gait of the short limb as also there is a tremble gait, unstable gait. So how do you describe this? You have to describe the patient is walking with bipedal unassisted with some component of the short limb gait as also the unstable gait. As we can see, now the examiner asks why you are telling us the components of both, because the shoulder is not only swaying side to side as in coronal plane, but also it moves ups and down. That is why it is known as the combined gait. So again, see the ankle and the foot. So what is the primary cause? Primary cause is significant shortening. So etiology may be mechanical defect in the proximal femur or any part, any area of the body. It may be due to inflammatory cause. It may be infective neoplastic cause. Now see, check this one. See, the patient is standing with this. See, patient standing with his one leg is flexed, one leg at the knee, but it is, that means it is short limb. Now check this one. We have to check from the side, from the back. So you can see here. So this one, see, check this one. This is very good. The patient is walking with, yes, shoulder is going up and down. Shoulder is going up and down. So this is basically, it is a short limb gait, isn't it? So it is an unassisted bipedal short limb gait without antalgic component. As you can see here, the face is absolutely painless, and there is stance phase is more than the swing phase. So there is no antalgic component. Now, what is the workout of the short limb gait? So in that case, as you can see here, so there is a short limb gait. How to know there is limb length discrepancy? There is the answer is, we will check the level of the heel. As you can see, the level of the heel is above this. Somebody tells it is the level of the malleolus. This is not the answer, because in inspection, you cannot identify the malleolus by only the inspection. So it is better to say that is the level of the heel. So level of the heel is as is high up. So this limb is shortened. So if the patient is asked to stand, what is happening? See, there is a coronal curvature, coronal deformity of the spine. So is it a true coronal deformity or the abnormal? It is a compensatory. Then ask the patient to sit and see. Once the patient sits, there's immediately this coronal curvature is corrected. That means it is due to compensatory scoliosis because of the short lower limb. Now again, so which component is affected? And see the discrepancy of the level of the heel. Now you can see the simple test. It is a Gallier's test. You can see both the limbs, both the heels in the same level. You have to check from the front as well as from the side. From the front, so it is equal. From the side, so this is the level is unequal. That means there's a segmental shortening of the femur. Now, which part of the femur is shortened? Supratrochanteric or the infratrochanteric? This is it. It should be done by the true length measurement. Now, see the abnormal foot measurement, abnormal foot progression angle. Check what is happening here. So how the child is walking? See the foot. Yes, see, it is the in-toeing of gait. So, but how the child is walking here? Now, the patient stands with both the limbs outside, and see, this is the out-toeing gait. As you can see here, so it is the in-toeing gait. This is the out-toeing gait. Now, if this, so next workout for this, it's you have to check the hip movements. If the internal rotation is more than the external rotation, that means there are several possibilities like anteversion, increased anteversion, internal tibial torsion, or the metatarsus adductors. So from the below, you can go upwards or above from downwards. So if the patient stands, we have to check from the front as also from the back. We have to check the too many toe signs from the middle side that indicates the metatarsus adductors. As you can see here, we can see as the patient to sit in this manner, and we check whether if the patella is facing forwards. So in that case, what is the limb position? If there is definitely an in-toeing gait. Now this is the accurate measurement. This is the plumb line test. If the patella is in its normal position, if we hang the plumb line from the center of the patella or from the tibial tuberosity downwards, that should pass through the center of the bimalleolar axis. So that is, if it is there, so that indicates there is no deformity. But still, if there is some internal torsion, so that the foot will go on inside. So it is further examined with the help of thigh foot angle in this manner. This thigh foot angle. Next is the hip rotation. As you can see here, there is internal rotation. This is much more than the external rotation, and in that case, if the patient is, you have to see the sitting attitude of the baby. This is not the W position. If the baby can sit in this position, this W position, this definitely the internal rotation is more than the external rotation, and there is a high chance of anteversion. So if there is anteversion but internal tibial torsion is not there, so in that case there is an internal rotation more than the external rotation, but thigh foot angle is normal. But if the thigh foot angle is internally rotated, that means it is an internal tibial torsion. So that is the way by which we can easily diagnose these three conditions. Now, if there is the external rotation is more than the internal rotation, you can see how the child walks. Now, how the child walks. See, this is completely outgoing gait. As you can see here. So, what are the differential diagnosis? So, you can check the internal rotation, hip internal rotation. As you can see here, the external rotation is extremely more than the external rotation. And this is a special test. Ask the patient to flex the hip. And normally, what happens? Once you ask the patient to flex the hip, this hip will go, there is a knee will go towards the ipsilateral shoulder. But on that side, it is go outside the ipsilateral shoulder. That means there is axis deviation. So there is axis deviation is there. That indicates there is external rotation is more than internal rotation. Once the hip is flexed, that is high chance of slipped capital femoral epiphysis. But at the same time, it can happen due to the external tibial torsion that can be easily diagnosed with the help of the thigh foot angle. But not only that, there is another condition, which is known as the miserable malalignment syndrome. This is in that case, so that is all are present. So if this external tibial torsion is present, that is only thigh foot angle is normal, and there is outgoing gait, but there is no axis deviation. But if the axis deviation is there, thigh foot angle is normal, that is only the SCFE. But if there is outgoing gait is present, internal rotation is more than the external rotation, as also there is the external tibial torsion, which is diagnosed by the thigh foot angle. And not only that, ask the patient to check whether the patella and the foot is going same direction or not. If the patella is facing front, still there is external tibial torsion. That is known as the miserable malalignment syndrome. And in that case, what is that? They said basically, if there is some external tibial torsion, so if there is some increased anteversion, there is an internal the increased internal rotation of the femur is basically compensated by the external significant external tibial torsion. So that is known as the miserable malalignment syndrome. So in that case, so if we correct the patella, in that case there is some the foot will go outside. So this is not the miserable malalignment syndrome. So in that miserable malalignment syndrome, there will be internal rotation will be more than external rotation. That indicates there is some increased anteversion. There is external tibial torsion, and that is diagnosed with the help of the thigh foot angle. This is not the miserable malalignment syndrome. Now see, this is the unstable gait. So this is the unstable gait. As you can see here, this is definitely, it is a lurching, and this is the gait actually I captured from my balcony of my house. You can check it. It's definitely the body is swinging side to side in the coronal plane. Definitely it is unstable gait or the Trendelmark gait. So what are the causes? Also know if there's any painful situation around the hip, that there is inability to move that reduces the efficacy of the abductor, that can lead to the Trendelmark gait, or there is supratrochanteric shortening, or there is a non-union, there is a defect in the fulcrum, or there is some instability like some dislocation of the hip, that can lead to trochanteric, that is Trendelmark gait. And the workout, you have to check whether it's the coxa vara, how the coxa vara, like there is some Perthes disease, or any cause of there is adolescent coxa vara, or the pathological fracture neck of femur that leads to coxa vara. Basic point for diagnosis is abduction internal rotation of the hip is restricted, but the other motions are normal. So that is the one. Next is the supratrochanteric shortening. We have to check it, and the significant total shortening we have to check. Next, the telescopic test and the Trendelmark test. These are the test workout for the unstable gait. As you can see here, if the patient is unable to stand, then we can, with the help of the indirect Trendelmark test, we can check. So basically, take home message. So take home message is the ABCPAC. That is the test to be, the points to be remembered during the gait examination. A is the adequacy. There is adequately should be undressed. it should be barefooted, at least 20 steps to be taken, at least in a normal speed. This adequacy. B for the barefooted, and it's a bipedal unassisted gait. That is most important. Patient should walk barefooted. Next is C for the this normal these components that should be stance phase should be more than the swing phase. Next. Next is P for the that is painful facial expression, and also there is some the foot progression angle. This is most important, and the pace is basically the speed, and C for the less the cadence of the speed is the same. So A, B, C, E, C, this is the most important points to be remembered during the examination, to be fulfilled during the gait examination. Thank you. Now, is there any question we can discuss?
Thank you very much, Dr. Pal. That was excellent, and a lot of information there covered in the short time. So I think there should be questions from the DNB students and postgraduates.
Yeah.
I hope there is.
Yes. If anyone have a question right now, please write it or ask directly. Meanwhile, you have explained one miserable malalignment syndrome.
Yes, yes.
So is it different from that in doing it? Means how the child will present with that?
Actually, miserable malalignment syndrome present with the outgoing gait. Basically, the primary cause is the increased anteversion. As because of anteversion, there's an increased internal rotation movement of the hip joint at the cost of restricted external rotation. So patient will initially walk with the intoing gait for the very beginning, and the nature will compensate with the help of the external tibial torsion. So in that case, gradually the toe is going outside, and ultimately patient will walks with the external outgoing gait. So in that case, if the patient will initially patient has the anteversion, there is external tibial torsion, because the compensatory. Okay, so in that case, so patient can sit like the W position. So there is the internal rotation of the hip is more than the external rotation. That indicates there is some increased anteversion. And in the thigh foot angle, that shows there is a external tibial torsion. And if the patient is asked to stand with the patella facing forward, so in that case, still the foot will go outside. That indicates there is a compensatory.
So one question from Dr. Sachin is the gait in tibia vera.
Yes.
Yeah.
Gait tibia vera, that means it is a genuverum deformity. So basically, it is almost like a waddling gait. It's a waddling gait. And similarly, if the patient is a genu valgum deformity, it is the outward thrust gait. As the genu valgum, patient is there's the relatively there is a lengthening of the limb. So in that case, the unilateral one, patient for the ground clearance, patient will go like circumduction, like make a circumduction outgoing, so that make a just rounding of the limb to make a ground clearance. So in tibia vera, there will be like a waddling type of gait, and then the genu valgum, there is almost circumduction, bilateral circumduction type of gait.
Sir.
Yeah.
Sir, in examination, we have to start with gait, or we have to mention gait at last after special test?
Yes, that is a very good question. So basically, it is always there are some controversy, and orthopedics there we are very fortunate to give some specific valuable explanations. If your explanations are scientific, then the examiner will take it. Basically, the gait should be examined first, because sometimes there is a mechanical problem. So mechanical problem, what happens during suppose the patient is walking for 100 meters, then only patient will complain of pain. So if the patient we start examination, after similar examination, patient then he becomes very much painful. So the patient will becomes severe pain, and that basically that will present with the antalgic gait. But if there is a mechanical problem, a little bit shortening, so there initially patient will have short limb gait, ultimately becomes it's a walking for a long time, then only patient becomes a painful gait. So after examination, the gait pattern may change. So we have to understand what is the primary gait pattern. So that is why the gait should be examined first.
Okay, I think there's always, if you ask 10 examiners, you'll get different answers. So I would say that if you're sure about the gait, start with it. If you're not sure and you're confused about the gait, put it last. Okay, but examine it first, as he said.
Thank you, sir.
So because, yeah, even when I was examining, I used to write gait at first for the lower limb examination and handedness for the upper limb examination, because I have fear that I will forget in writing or in
Mhm.
telling about the gait if that flow will not.
Exactly.
And the
Yeah,
only
that's
problem is if you are confused about the gate and you start with it, you might end up your whole viva just on that. So if you're sure about the gate, it makes sense. But if you're not sure about the gate, it may be safer for you. But examine it first, put on what you see. I think if you follow what you're actually seeing, you would usually not get into trouble. When you start trying to imagine what the problem is, or you have some idea of the diagnosis and you're trying to build your findings around the diagnosis, that you'll end up in problem.
Exactly.
Thank
So if you know the gate, that is a very, very solid reason for your points in favor of your diagnosis,
Yeah.
isn't it? So that is why we had I have given whole class on the gate, and now I'm here to obviate any confusion. So suppose there is some mixture of the gate. So in that case, examiner, the student may start with this. Okay, is my
We
So
lost it for a
your
moment.
yeah.
my video is not working?
No, not working, sir.
Okay.
That's okay, as long as we can hear your voice.
Okay. Okay, just there is some technical problem, I think. Okay,
Yes.
basically, what is happening? So, if there's any confusion about the gate, so in that case, just we can you can start with describing that this the patient is complaining of bipedal unassisted gait with tendon component or painful antalgic component like that. So this is very easy to. So what is now the examiner may ask? Let the examiner may ask the questions. Why you are telling it is a unassisted gait? Why it is a bipedal unassisted gait? Why you are telling it is antalgic gait? Why you are telling it is a tendon component? Then you can start with. So you can earn some questions, some points, or some times from your examiner. So if we ask, if you give the proper explanation, that will increase your confidence. So that is how you guide your examiner for giving numbers, isn't it? So it is very interesting.
Yes.
Sir,
Sir, yeah.
Sir, in unstable gait, it means that there is a problem in two plane, coronal and up and down.
Yes, coronal plane and also the upward and downward. So if the patient is walking with the shoulder is going up and down, so that is basically it is a short limb gait. But if it is a swaying of the shoulder side to side, that indicates it is a Trendelbach gait.
Oh, sir. Thank you.
So he
One more
was
question.
asking, yeah, he was asking about that, sir. If it is unstable hip, then it is a two plane deformity. Is it always so, sir?
Maybe, yes, that is why I'm telling. If there is any doubt, then you can describe the gait. Patient is walking with this point like this. So if there is no at all, all the components like the unstable points of short limb gait, everything are already mixed. So in that case,
So I think what basically, if you have a positive Trendelenburg, that means there is some instability. Simple as that. Okay. If it is simply a short limb gait, it will not be unstable. It will be stable. Okay.
Yes,
But the
sir.
moment you have a weakness of muscle or a subluxated joint or a dislocated joint or something like a girdle stone, your limb is not going to be, you'll have a positive Trendelenburg. That means that hip will fall down when you're putting weight on the other side. Yeah? Because the abductors cannot lift that hip up.
Yes, sir. One more question, sir.
Yeah, sure.
Sir, in describing gait, we have to describe unassisted bipedal gait, then start with shoulder, buttock, knee, everything, sir. Foot. We have to describe everything.
please repeat.
Sir,
yeah.
in describing gait, we start with unassisted bipedal gait with shoulder moving, this buttock going down, Yeah, knees flexing or not. So everything we have to describe, sir. Front, back, and sides.
Yes. So what is the question?
Sir, how to describe a gait in front of examiner that you want?
Every joint,
Is
sir.
that
So
already told? No, I've already told. You have to ask the patient like a adequately undressed, barefooted, and walk in a straight line. And at least you have to check there is the to and fro walking, to and fro walking at least for 2 to 3 times. So that is at least there are 20 steps. 20 steps should be examined, and you have to examine from the front, side, and back. That is the
So,
way.
yeah, he was asking, sir, when we are describing to the examiner, is it so that we should say the name like Trendelenburg gait, or we should explain that his shoulder is lurching on the outer side like that?
You start describing like this. That is, the patient is walking with unassisted bipedal gait with Trendelenburg component or antalgic component or short limb component. I'm repeatedly telling that let the examiner ask the questions.
Yeah.
As you know the question answer, so it is very easy to answer that questions. So it is very okay. Or you can tell there is two components are mixed with each other. That will be easy for you. Okay.
Yes, so things like short limb and Trendelenburg can often go together. Okay.
Yeah, exactly.
You need to be clear about your examination and what you're looking for. So you talk about the Trendelenburg component and the shortening component.
Exactly.
Antalgic, again, the stance phase will be shorter than the opposite side. Simple as that.
Exactly.
Yes. Any other
Don't
question?
try to get too confused with it, because if you try to
It is no harm.
it can become difficult.
Exactly. It is no harm to tell like that. So the patient is walking unassisted bipedal with mixture of the antalgic and also the Trendelenburg gait. Then what are the points in favor of antalgic? The patient is walking with painful facial expression and the short stance phase than the swing phase. Now we're telling this Trendelenburg component that this is the answer, like this. It is very easy.
Okay, sir. If something is more prominent, like that should be come first, or is it mix type
Like,
of gait? We can, yeah, that one also.
Sometimes yes, non-prominent means sometimes the patient walks with some obvious knee flexion, hip or knee flexed. Patient is suppose I'm just telling. Suppose the patient is walking with a crouch gait. So crouch gait, patient is walking with bipedal unassisted gait with both simultaneous both the hip and knee flexed. It is simulating as a crouch gait. Okay, so now what is your inference? So this inference is maybe a crouch gait, and that maybe has a hamstring spasticity. Okay, or if there's some toe gait. Actually, basically, there's a general class. So in that, that is why I'm not included those conditions. The cerebral palsy, it is very easy to diagnose. So this is obvious. In cerebral palsy, basically, it may be due to the spasticity, it may be due to the rigidity. It may the spasticity means if the lesion of the brain is in the cerebral cortex. Rigidity means if the lesion of the brain is in the extrapyramidal system. Then there is the ataxic gait if the lesion is in the cerebellum, and there's a mixture. So if it is a spasticity, so there are basically the two joint muscles. Those muscles are the two joint muscles. Two joint muscle means the muscle which crosses the two joints. Basically, there are basically 3 or 4 muscles in our body which normally that are two joint muscles. These are affected. Now the cerebral palsy is very, very easy. Now I'm telling you, just if you examine the gait. Now, if there is a gastrocnemius involvement, so gastrocnemius is a two joint muscle that crosses the two joints. So there is a toe gait. Patient is walk with both the toes on the ground. Suppose it's a bilateral equinus gait like this. So basically it's known as the toe gait. So patient is walking with only the touching of the toes only. So there is a heel to toes pedal rhythm is disturbed. So in that case, the patient, you can describe it like that. Patient is walking with the disturbed heel to toe rhythm. This is walking only on the toes. So basically it is a toe gait. And so that is it's suggesting that there is a possibility of bilateral equinus deformity, or it may be due to some the gastrocnemius spasticity. If it is a hamstring spasticity, then it's a crouch gait. So patient is almost walking in a sitting posture. Okay. Now it is if it is a gracilis involvement, gracilis, it is again it's the two joint muscles. So in that case, scissori gait. It is a scissori gait. Okay. Now, so this is known as the scissori gait. And lastly, if it is a rectus femoris gait, the rectus femoris is a very stiff gait. There's a whole, the knee is completely stiff. So patient is walking like this stiff knee gait, like both the bilateral stiff knee gait. So this is the it's for the spasticity. If it is a rigidity, that means the extrapyramidal system is involved. That means the athetosis. So there's some involuntary movements. Some like patient is walking like a dancing, that's simple, abnormal, incoherent, inconsistent movements, like he will walk like a dancing. So it is known as the athetoid gait. If it is ataxic gait, so there is a high chance of falling. So patient will fall like that. So in that case, so what will happen? Patient will both the limb will keep both the limbs stretched, and so in that case, if we try to make a balance like this is like a perching. So this is the perching gait. So it is a very minimal involvement. So there is a low perching like that. If it is a moderate involvement, like the medium perching, which is a very highly unstable gait, highly ataxic, there is a high perching gait. This is the same manner, though the person is doing like walking on a rope, like the mother is like the mother is they show some magic moments in the village, isn't it? The bacha log, they are walking on a rope and they are trying to make a balance on this. The same thing is happening also in that ataxic gait. So it is very easy to diagnose. So these are the obvious manner. So the patient is walking with a perching gait, with both the limbs, both the upper limbs outstretched with each other, and to make a balance. So this is known as the perching gait.
So just one question, sir. That in the Trendelenburg gait, is it always that Trendelenburg test should be positive? Because sometimes once it happens to me that is clear-cut Trendelenburg gait, but I was not getting the test positive. So how to?
Yes, it is a very good question. So basically, Trendelenburg gait is the dynamic equilibrium of the Trendelenburg test. So in that case, if the Trendelenburg gait is there, you should get the Trendelenburg test positive. But in some conditions, there you cannot find it. So what are the some conditions? Like the hip is stiff. So in that case, what are the prerequisites of Trendelenburg test to be positive? It is, you have to understand. So in that case, Trendelenburg test to be positive, there is some gradual adduction. If yes, but if the pelvis is very stiff, like fixed pelvic obliquity, so in that case there will be no movement of the pelvis going at all. So that is why you will not find that the movement of the pelvis. Do you understand? So that is why this is the fallacies that even in spite of the Trendelenburg test positive, Trendelenburg gait is positive, but you are not getting the Trendelenburg test positive. You understand?
So in those, if you're not getting it, you should try doing the delayed Trendelenburg test. Okay.
Yes.
So you may not be positive, but do the delayed one. Sometimes it will take some time for the hip to tip down.
Exactly. Delayed, or you can do the indirect Trendelenburg test. Indirect. Yes, you can do that.
What is indirect, sir?
Indirect is you have to check, you have to ask the patient to keep both the hands, your examiner's hand, and take one by one leg up above the ground. In the side which is unstable, you will get much more pressure on your hand.
Okay, I think if there are no more questions, we should bring it to a close today. Thank you very much, Dr. Pal. As usual, very informative and useful discussions and the talk. And so until next week, bye to everybody. We will post what the next topic and who the speaker will be sometime during the week. So bye, everybody.
Thank you very much, sir.
We will carry on this common mistakes, common says.
We'll
Thank you, Dr.
Okay.
Okay, thank you. Bye.
Thank you very much, sir. Thank you, sir.